this evening we're going to discuss psychiatric emergencies, and obviously there are more than one psychiatric emergency that you might come across. But there's a couple of scenarios that constitutes a psychiatric emergency, and the two we're going to discuss this evening is the agitated and aggressive patient, and secondly the suicidal patient. However, not to forget that psychiatric medications can cause sometimes significant side effects, and that in itself can constitute a psychiatric emergency. And then also something that people don't necessarily know much about, and that is malignant catatonia, that for some reason we see quite a bit in the Eastern Cape and here in our area, and I've seen more here than in other provinces where I work, but it can actually also be a psychiatric emergency, but I'm not going to cover those two subjects this evening. So what we are going to look at is the management of the agitated and aggressive patient, and then also the management of the suicidal patient. So firstly, when it comes to the agitated and aggressive patient, we actually as doctors tend to be, and healthcare workers in general, I suppose, we are generally ill-prepared to manage acutely aggressive patients. So there's a need for a systematic approach that when you're going to have to deal with an aggressive patient, or you hear an aggressive patient in the background and you're working in casualties. I always try and make that the scenario. You have to take a number of factors into consideration. So firstly is to identify that patient, that potentially violent patient, and recognizing the warning signs if the behavior starts to escalate. And I can honestly say it took me a while working as a psychiatrist already to adequately appreciate risk in a violent patient, and to see it coming way before it happens. And it caught me unaware a few times early on in my career. So you need to have a system or a systematic approach to this. You need to know what you're going to do before the interview. You need to know what verbal de-escalation entail. How do you try and talk down a patient? If this doesn't work, you need to know how to physically restrain a patient. And then also you need to know if you physically restrain a patient, how are you going to rapidly sedate the patient? And we refer to this as rapid tranquilization in psychiatry. So firstly, preparing for the interview. So I always say that when I teach the medical students, you're probably or possibly going to hear this patient before you see the patient. And you might see a commotion, you might hear the nurses, you might see people becoming nervous if the patient's already in a state of agitation. And then you need to know how you're going to approach this situation. So firstly, make sure that there are no weapons on the patient, him or herself, and there are places where people need to go to metal detectors. But one of the ways and we don't always have that in South Africa. In fact, I think very few emergency units would have metal detectors to ascertain if there's something of some kind of weapon in a patient, on a patient. But anything can be used as a potential weapon, and you need to be aware of that. So in the environment on the patient itself, it can be things like knives and stuff like that, but even more than that. Ishmael Shibani raised a hand. Marilyn, I'm just going to ask you to interrupt me if there's anything that I need to be aware of. Is this something, is the sound quality fine?
We can hear you well, Prof.
Okay, all right. And so on the patient himself or herself, they might have anything that is even something like a pen can be used as a weapon. And then in the environment, again, anything from an ECG machine to a drip stand can be used as a weapon. And then on yourself, do you have a pen on you? Do you have perhaps a stethoscope around your neck. That could be used not for the patient, but against yourself, and you could possibly be strangled with that. So those are things that you need to be aware of. One of the things that happened to me personally is when I didn't appreciate a potential situation escalating was I was doing a ward round one day, many years ago. And the patients kept walking past where we were doing our ward round and coming into the area every now and then. And at some point, I stood up and I walked to this patient and I said, "Excuse me, but we're busy with a ward round. Please leave." And I was still wearing ties at that stage. I never wore a tie since. And the patient grabbed me by my tie and started strangling with me with my own tie. And all I can remember is my tie in this horizontal position and all these hands of people jumping up to help me and to help loosen the hands of the patient around my tie. So be aware what you have on yourself. Do you have a pair of scissors on you? Even your glasses can potentially harm you if you get knocked in the face. Then the second thing that I always make my students aware of is be aware of what's going on in your environment, what's going on in your surroundings. Where's the interview taking place? Where's the exit? And where's the patient in relation to the exit? And try and never place yourself in between the exit and the patient, with the patient in the middle, in front of you in terms of the exit. So place yourself closest to the exit. And again, I realize, I've worked in many places in South Africa, and I realize that our A&E units are very poorly designed in this regard. And this is something that you must maybe tomorrow go back and have a look at where these interviews take place and what it looks like there. Then also try and well, hopefully after today, you'll know what are predictors of behavior that's escalating and what are the symptoms of escalating behavior. Make sure that wherever you are, that the interview and you are visible to others if you are worried about potential aggression, and have a security guard on standby. And I'll tell you more about that in a moment. So identifying the potentially violent patient, we are actually known to underestimate the potential for violence. And the best predictor of future violence is a past history of future of violence, a past history of violence. So as you are approaching this area, what I usually suggest is try and get a little bit of history from whomever is available. So if it's the family that brought in the patient, ask them about how the patient behaved prior to them bringing the person to your attention. It might be actually be at a clinic. So ask them, what was the patient doing? What made them afraid of the patient? Secondly, if it was the police, ask the police how the patient behaved when they got to the patient and how the patient behaved on the way here. And lastly, the nurses will also be able to give you some information as to when the patient arrived at the A&E unit and how they've behaved since. And then violence seldom is out of the blue. There's usually a period of mounting tension. So look for this escalating behavior and look out for these signs. Learn to identify nonverbal cues as well as verbal cues. So we are always very aware as psychiatrists of the body language of a patient, the facial expression of the patient. Sometimes you can actually see the hostility in a patient. So if the patient starts becoming more and more psychomotor active, restless, and pacing up and down, know that something is up and that you need to make sure, and then become very vigilant of what is going on around you. Or the patient starts raising his or her voice. So other signs of impending violence, I mentioned an angry or a hostile look, confrontational behavior, taking you on as a person. And remember, it's not always the psychotic patient that might be aggressive. It might be the personality disordered patient. It might be the patient who's intoxicated with substances. So it's not always a psychotic patient. It might even be a patient in a delirium. that becomes aggressive. So look for that confrontational behavior, and the confrontational behavior you I think probably see more with your personality disordered patient than with a patient that is in a psychotic state. Loud, aggressive speech or shouting, pacing, like I mentioned, tense posture. You can maybe see the shoulders and the fists clenching, and then aggressive acts like pounding the walls, hitting the person, hitting themselves in some way. So these are all signs that should make you aware that there is a potential for violent action. So if you get that uneasy feeling, that gut feeling, that you feel slightly afraid, and let me tell you, it's okay to feel afraid. I physically ran away from a patient I remember as a registrar, and when I took the history before I arrived at the patient, I heard that the patient had on the way there actually broken a police officer's jaw, and by hitting the person, and this person started running at me, and I turned around on my heels and I fled. And I keep saying to the medical students, you are not there to be heroes. So if a patient starts running at you, run away, get out of the way. Or if the patient is running for the door and it's you between the patient and the door, get out of the way. Let the patient run, and then gather forces and call the police and take the necessary action to go and get the patient. But never ever downplay threatening behavior from a patient. So take appropriate precautions without delay. Be aware of your surroundings, and if you feel the need, remove yourself from a situation. And again, I especially say this to the medical students. If you're doing an interview and you start feeling uncomfortable and the patient's behavior starts to escalate, excuse yourself from the situation. Say, I need to leave this interview, and then back away. Never turn your back on the patient and go and call for help. So what is verbal de-escalation? Before we use rapid tranquilization, we try and de-escalate a patient by talking to them. And some patients may be agitated but cooperative. I remember many years ago that especially around the time when the disability grants pays out, that was the one time, and the other time was around the festive seasons, that the patient's family would agitate the patient to get them out of the way, in a sense. And then the patient is agitated for a good reason, but cooperative. So once you sit down with the patient and you start understanding why they're agitated, they start to calm down. So that's what you first would like to do. You would like to try and talk the patient down. So remember, stand at least 2 arm lengths away. You don't want to be too close to the patient. Don't approach the patient from behind. Don't make any sudden moves. And what I've learned is that I will always speak with my hands in front of me. But what you can do is you can kind of slightly change your body so that you have a slightly side-on view. So that actually makes you from this to a slightly smaller target if the situation escalates, and you keep your hands in front of you, your palms facing upwards, which is a very non-threatening way to speak to somebody, but it's also a way that if something comes your way, that you can protect your face and yourself. Adjust the tone and volume of your voice. So I would start speaking slower. I would pronounce my words better and slower, and lower my voice, and start and try and speak to the patient in as calm as possible a voice. Offer a soft chair or something to eat or drink, not a hot beverage, but patients respond to that sometimes, and something like a jelly tot or a gummy bear, something soft like that, would sometimes help the patient calm down. They might ask you for a cigarette. Obviously, we can't smoke in the buildings, but if that's what the patient wants to do at that moment, that they want to go outside, I wouldn't stand in their way if I think this situation is potentially escalating. And then set boundaries. So in a calm tone of voice, say, I can help you with your problem, but I cannot allow you to continue threatening me or the staff. So that's setting a boundary, telling the person what is acceptable and what is not. Address emotions directly. Tell the person, you look angry. You feel like hurting yourself or someone else. So by that, you are validating their feeling, their emotion. And then if the person starts to calm down, offer the patient oral medication. And it would be similar to the other rapid tranquilization that we use when we physically restrain somebody. So it's something like lorazepam or haloperidol or risperidone that you can offer the patient. So this is actually, I read in an article on managing the aggressive patient, but it was taken from the business world, and it's the 3 F's: feel, felt, and found. I understand how you could feel that way. Others in the same situation would have felt that way too. So here I'm talking about that patient that was agitated by the family to get them out of the way, for example, or who has been misusing their money. And most have found that doing this or that could help. And then you can offer help and say, okay, let's calm things down, let's de-escalate things, and maybe sleep over this evening, and tomorrow we look into this in a calm way. So this way you are validating that they are in distress, and you're not confrontational. And that's definitely what you shouldn't be. Don't try to match the loudness of the patient's voice. Don't be condescending. Don't criticize the patient. Don't interrupt the patient or keep interrupting the patient. Don't argue with the patients, and don't take insults personally. Now, it's easier said than done. I realize that I've been in these situations myself, and you're anxious, and you're afraid, and these are ways that one tries to assert yourself. But in a patient that you feel that you can't predict what their behavior is going to be, this is not the way to communicate with them. Then, unfortunately, sometimes you will realize that verbal de-escalation is not working, and your timing depends a lot on experience, they say. So the intoxicated patient is notoriously difficult to reason with, and then you're going to start seeing escalating behavior, and you don't want that. You want to act before this is escalated into something that you can't control, or that somebody's going to get hurt. And there's maybe something to be said for like a kind of a code language, that so you've already alerted people to the fact that there's an aggressive patient. Your security guard is on standby, and you might say, Mr. Security Guard or Miss Security Guard, please call Dr. Armstrong to come and assist. And Dr. Armstrong would then be code for, I need help. I need somebody to come and help me contain the situation. Then when it comes to the physical restraint, and I need to be cognizant of the time always, because I can talk a lot and I would like to leave some time for questions. So physical restraint of a patient can be used when you weren't successful in verbally de-escalating the patient. So the indications for this is if there's imminent harm to others, if there's imminent harm to the patient themselves, or if there's significant disruption of important treatment or damage to the environment. And again, in a casualty situation, in an A&E situation, this is something that you also need to be acutely aware of. So restraint team always consists of 5 people, with one the team leader, and the team leader should be decided for it. So this is something that you need to write into a policy, and everybody in the A&E should know beforehand what to do and what to expect when you have a situation that's escalating. It is the only person that's giving orders at that moment. It is the person with the most experience, and it does not have to be the doctor. So what I always use as an example is, I remember working in a rural hospital many years ago, and there was a nurse, a specific nurse, and she was quite intimidating in her presence, but with a very calm and reassuring voice. And I would always want her to be in the vicinity, and I would always want her to be the team leader. And then there was another 1 or 2 nurses that actually, instead of calming things down, would aggravate things. So be aware of those people. And I'm not saying it's always nurses. It could be doctors for that matter as well, or any other people working in the A&E unit. But be aware that there are certain people that do not handle situations like this well, and they would be heard in the background, or they would aggravate the patient or start shouting at the patient, and this can then escalate very quickly. And I would actually ask people like that to leave the scene and say, listen, let's give us some time to handle the situation. So before you enter the room, so you've now left the room possibly, the leader explains the restraint protocol, runs through it with everybody quickly. Each member is assigned a specific limb or body part to restrict movement in. So it's not going to be very helpful if you say to 4 people, each go for a limb and everyone goes for the left arm. That's not going to be very, very helpful. So the team members removes all their personal effects, like their ties, their glasses, scissors. We've mentioned that earlier. And then if the patient to be restrained is female, it is advisable to have at least 1 member of the restraint team being female. And then the major types of medication that we're going to use in a situation like that would be, firstly, the benzodiazepines like lorazepam. I'm going to talk a little bit more about the benzos in a while. Your first generation antipsychotics like haloperidol. And then also we have second generation antipsychotics like olanzapine that is now available in an intramuscular format that is also very useful and that we use actually quite frequently in psychiatry. So like I said, firstly, always give the patient the option of taking oral medication, even if the team is ready to restrain the patient. Sometimes the patient with the show of force would start cooperating. The same patient that I ran away from at a different admission a couple of months later, I can't remember exactly how much long afterwards, but this patient became aggressive during a ward round that I was actually doing, also a ward round, different hospital, completely different hospital. I was a registrar at the time. And I asked the patient to go to his room. And then when I went there with the restraining team, he immediately backed off and he took oral medication. So lorazepam, we can give 2 to 4 milligrams per hour stat. Or if you don't have lorazepam, we also use clonazepam, usually half the dosage. Or you can use diazepam, 5 to 10 milligrams per os, or haloperidol, 5 milligrams per os. And then if you're going to go the intramuscular route, there are a few things to remember. The golden standard, still to this day, is a combination of lorazepam and haloperidol. But at the moment, I think there's a problem with haloperidol actually it's a worldwide problem, or I'm not sure, but I do think that there's a problem with accessing haloperidol at the moment. So 2 to 4 milligrams IMI and or haloperidol combination, and you can repeat the dose after 30 to 45 minutes with a maximum of 3 doses in a 24-hour period. Or frequently we have the situation of things being out of stock, and we've had a situation where lorazepam and haloperidol is not available. Then you can use clonazepam. Again, like I said, half the dosage, 1 to 2 milligrams, and you can repeat 4 hourly with a maximum of 10 milligrams per 24 hours. Or promethazine. Promethazine actually works quite well, and we also use that quite commonly. And you can use 25 to 50 milligrams IMI and repeat 4 hourly. And what might not always be available in the public sector, but is probably available in the private sector would be olanzapine, 10 milligrams IMI. Something I need to mention here is that a lot of people ask me the question about clopixyl acufase. Clopixyl acufase let's just stay with clopixel Accuphase, is not acutely sedative. It's Halloween, so if you hear noises in the background, there are kids walking around in our neighborhood and trick-or-treating, so apologies for that. Where was I? Sorry, I got distracted by people dressed very funnily outside my window. Do not give diazepam IMI. You can give diazepam orally, you can even give it IVI, even though with a very acutely aggressive patient, getting a needle in is probably going to be quite difficult. But do not give diazepam IMI because your absorption is very unpredictable. Right. So how do you execute this? Your team enters the room in a force and display a professional rather than threatening attitude. The leader speaks to the patient in a calm way, explaining why restraint is needed and what is going to be happening now. The patient is then instructed to cooperate and lie down to have medication administered, and if it becomes necessary to use force to control the patient, one team member restrains the pre-assigned extremity by controlling a major joint, a knee or elbow, and trying to lock that in extension. And obviously you should know how much force to use or not use, and you don't want to injure the patient. And the team leader controls the head, and then somebody else administers the medication. So this is a graphic way of explaining how it is done. So the team leader takes the head, and when the patient is prone and supine, lying down, and because a person can move their head around and can try and bite somebody, and then somebody with each arm and somebody with each leg, and then a sixth person administers the medication as I just discussed. So once sedated, now sometimes you have very little information and things escalated very quickly. You need to ascertain whether the cause of aggression was medical or psychiatric. So you need to exclude a delirium if you're unsure. So something that very quickly a person that became very aggressive, and you figure out afterwards the patient is now sedated, that this patient has no history of mental illness. They became ill quite quickly, or confused quite quickly, and then became aggressive. You must consider delirium as a possibility. And then, of course, whilst the patient is sedated, you need to monitor the vitals regularly. So this is an algorithmic approach, and it's very similar to what I just told you, but it's nice to have an algorithm up somewhere in casualties where you know how to approach the patient, and then you can go, if you know you've just been called to casualties, quickly scan the algorithm and decide how you're going to approach the situation. Right, and I see we have 26 minutes left, so I'm going to cover the suicidal patient and try and leave about 10 minutes for questions as well. Okay, moving on. About or more than 800,000 people every year die by suicide, and the most common methods used worldwide is pesticide ingestion, hanging, and firearms. And amongst those who have died by suicide, 80% had contact with a primary healthcare provider within 1 year of their death. We know that more males die from suicide because they tend to use more lethal methods, and we know that females tend to have more suicide attempts than males. So it is important to have an approach to identify and manage the risk factors of somebody who you think might be thinking of taking their own life or just harming themselves. So you need to know how to assess for suicidal ideation and behavior. And again, when I teach, I always say that if you take a history of a patient with depression, your last question as you go through the symptoms of the DSM-5 symptoms of depression should always be, have you thought of taking your own life or harming yourself, or felt that life is not worth living? So that's how I usually phrase it. And if a person says yes, immediately from there on, you need to go to a risk assessment and decide how imminent is the risk for this person to harm themselves. There are different terms, and vocabulary is quite important. And I know people personally have lost loved ones to self-death, and I know that we in medicine and psychiatry tend to use the word suicide and suicidal quite often, but please be aware that some people are very sensitive to the vocabulary that you use when discussing suicidal thoughts. So we like to say that a person does not commit suicide, because commit implies that the person committed a crime. And this is, it couldn't be further from the truth. So a person dies by suicide, and we prefer the word self-death actually to the word suicide. But for the purpose of this conversation, I'm going to refer to it as suicide. So we, because that's what we see in the handbooks and the literature as well. So you get something like suicidal ideation. A person is thinking about taking their own life. A suicide attempt, they made an attempt at harming themselves. A suicide threat, they're threatening to self-harm. And then there are non-suicidal self-injurious thoughts and non-suicidal self-injury. We refer to that as self-harm. And obviously, if the person was successful, that is a successful suicidal self-death. And again, the strongest predictor of suicide is the history of previous suicide attempts. So if a person says, yes, I have thought about taking my own life, then my second question is, have you ever attempted to do this? When was the last time you attempted? What did you do? And so you kind of, the one question leads to the other. And obviously, if a person admits this to you, they are in distress, and one needs to be very sensitive when going down this line of questions. So there are multiple psychiatric comorbidities that are at a higher risk for suicide, most notably bipolar type 1, alcohol use and other substance abuse, schizophrenia, personality disorders, major depressive disorder, panic disorder, and post-traumatic stress disorder. So what are the risk factors? Somebody who's single, they say that the unskilled occupations, there are more suicide than skilled occupations. And I know that in the UK, for example, in builders, there's quite a high suicide rate. And then amongst skilled workers, doctors are actually at an increased risk of suicide compared to the general population. Something that we know makes a difference as well as childhood adversity. So there's a 2 to 4 times greater chance in adults who suffer childhood abuse or other childhood experience to have a suicide attempt. And then very importantly, and that's why you need to ask, once a person answers in the affirmative, about a history of suicide in the family, because we know that there's a heritability of suicide which varies between 30 to 50%, which is very high. General medical illnesses also that predisposes that there's a higher risk of suicide includes asthma, cancer, chronic obstructive pulmonary disease, coronary artery disease, diabetes, epilepsy. I think in epilepsy, the suicide risk is 6 to 9 times higher than the general population. Spine disorders, interestingly, stroke, recent surgery, and chronic and terminal disease. So chronic pain, chronic back pain, cancer pain, arthritis, traumatic brain injury, again, the risk is the greatest within the first 6 months and remains elevated for at least 7 years, and that's regardless of the traumatic brain injury severity. Protective factors are social support, family connectedness. Obviously, pregnancy is interestingly a protective factor, parenthood, and people who have a deep faith tend to also, that tends to be a protective factor. So when you ask about suicide, remember that the fact that you're asking will not cause or exacerbate the suicidal thoughts of action. In fact, it's quite the opposite frequently. People are relieved to be able to talk about these thoughts that they've been having and probably have been hiding from most people. So you ask about the frequency and persistence of the thoughts, including the duration. Have they thought of a method? Have they started thinking of a plan? And that will all show you what the intent of this person is in terms of self-harm, and also how imminent it might be. So active suicidal ideation is, I want to end my life and die. Passive suicidal ideation would be, my family would probably be better off if I was dead. So when you assess the risk and the degree of intent, you want to know about the plan. You want to know, are there means of committing suicide? In other words, are there pills available? Have they made plans to get a rope or to get pesticides or things like that? What is the lethality of the plan? If they're thinking hanging or using a gun, that's very lethal. What is the likelihood of rescue? Is the person planning in such a way that somebody will find them or somebody will not find them? So if they're planning that somebody will not find them, that is actually increased risk. Have preparation been made, as I mentioned, a history of impulsive behaviors or substance abuse, and the availability of support systems, and like I said, a family history or past history of attempts. There is the so-called no harm contract, which is widely used, but actually the evidence to support it is not great. So an open conversation between you and your patient to establish a therapeutic alliance, as well as ongoing assessment of the suicide risk over time, may be just as or even more effective, research has shown. So in terms of management, you want to immediately reduce the risk and draw up a treatment plan, and then manage the underlying factors and specifically address the psychiatric disorder and treat that to the best of your ability, and then monitor the person and follow up regularly. The tricky thing is to decide how imminent the risk is, and sometimes it means that the person has to be admitted involuntarily if you feel that the risk is imminent for this person to harm themselves. But like I always say, not everybody with suicidal ideation can be admitted or should be admitted. There are ways to mitigate risk if a person has these thoughts. So high risk, if they have attempted or want to attempt with a lethal method, if they've taken steps to avoid detection, if they are unwilling to discuss the suicide attempt, if they've had a suicide attempt or what precipitated it, or unwilling to discuss safety planning. So, for example, you would want to get the family in and have a discussion with them and ask their help if you're going to send the patient home, and say, please make sure, and this is together with the patient in a non-threatening way, please go home and remove all manner of potential things that can be used for a suicide attempt, like ropes and medication and things like that. Substance use disorders, lack of alternatives for adequate monitoring and treatment. So if this person has to go home alone and there's nobody to look after the person, so it's useful to say, well, can you live or stay with a family member or a friend? And obviously having a discussion with this family member or friend and asking if they're okay with looking after this person. And then agitation, if the person is agitated or impulsive, if they're severely hopeless, and if there's poor social support. These are all high-risk factors. So in terms of a practical way of approaching the outpatient, involve people close, provide 24 access to clinical support. So tell the person this is the number that you can contact in emergency, have the SADC support line, suicide support lines handy to give to the person, give them the number of the hospital, tell them if you feel that these thoughts are becoming more persistent, come back to hospital and let's discuss again. Instruct the patient's family also to return the patient. restrict access to means of suicide, communicate a commitment to help the person, and then educate them regarding the disinhibiting effects of alcohol and other drugs in a situation like this. So the safety plan, you talk this through with the patient, and you avoid situations that might precipitate suicidal ideation, like conflict at home, anticipate problematic situations like interpersonal conflict, for example, draw up an inventory of the medication, household poison, sharp objects, firearms, ropes, suggest individual coping strategies, identify family or friends that can be contacted to help distract or lift the mood, and provide telephone numbers like I mentioned. So once immediate safety has been ensured, healthcare providers should address underlying factors, including the mental illness, the precipitating events, and the ongoing life difficulties. And invariably, there would be ongoing life difficulties that needs to be addressed, whether it be relationship problems, financial problems, etc. And then, if a person had an attempt, ask them afterwards, what was the precipitating event? What was the thing that made you do it at that moment? And remember, not everybody that has had a suicidal attempt necessarily have been in distress for a long time. The amount of teenagers that I used to see when I worked in acute settings, who after a breakup of a relationship had a suicide attempt, was actually quite high. And I know from talking to colleagues in the general hospitals here locally, is that the psychologists say that they have to deal with this on a daily basis. So you need to refer this person for appropriate psychiatric and psychological treatment if they've had an event. Right, and I know I rushed the last part, but I see there are quite a number of questions, so I'm going to stop sharing and take some questions.
Prof, so the first question that we have comes from Ian Philbrick, and he wants to know what your recommendation would be for chemical restraints in a pre-hospital environment, so in the EMS.
That's a good question, and that's a question that I've also had in a clinic setting, and I suppose it's easier in an A&E setting than in a clinical setting, because the moment you you've sedated the patient, then the police will probably not assist in taking the patient, let's say, from a community health clinic to the hospital. So it's a very tricky one, but you also have to use your clinical judgment. And I see, Ian, you also say that SAPS is not very helpful. There's a document and that is actually on the internet, and it was drawn up quite a number of years ago, actually spelling out the responsibilities of the police in helping or taking an aggressive person to a casualty setting, for example. And it would be worthwhile, I can share this with Marlene for distribution for the attendees this evening. So what I used to do is, if I had a situation like that, I would ask the police, who's your officer commanding, and then go straight for the officer commanding and send him this document, or her this document, say you are obliged under the Mental Health Care Act to assist in this situation. Okay, so did I answer the question, Marlene? I got sidetracked. I opened the questions myself.
Yes, Prof, I think you answered it. I think it would also be important to know what they have access to in the pre-hospital environment, because I do think there's a difference between what the private sector and the government sector would have access to.
Ian, and thank you for your questions. I see all your questions here, and I can see that this is not the first time that these questions comes from a place where you've had to deal with this a number of times, and I have no doubt about how challenging these situations can be. And you're actually quite right about ambulances in terms of being confined and many weapons being available. So you have my absolute sympathy there.
Then the next question, Prof, comes from Brian, and he's asking, should there be an inquiry or legal action if we fail to contain a patient and the police don't respond on time and the patient does go on to harm him or herself?
The short answer, Brian, is yes. There should, but again, like I said, I know the police isn't always keen to assist, and one of the excuses would frequently be, but it's a known mental health care user, we're not going to touch the patient. So there should be an inquiry at least, and legal action is quite possible in such a situation.
The next question comes from Ntombekle, and she's asking if one can safely sedate an intoxicated aggressive patient.
Great question, because you always have to consider what is going to be. So if a person is already intoxicated, especially with or specifically with alcohol, you know that it's a suppressant. And if you add a benzo, then you're going to suppress the consciousness even more, and you might even suppress breathing. So I would, in a situation like that, so is safely, it's very difficult to answer safely or not safely. It depends on the substance that the person has taken and how much of the substance the person has taken. But I would rather, if I know this, go for something like an antihistamine, like Phenergan, like I mentioned, or for an antipsychotic like haloperidol, than going for a benzo.
The next question, Prof, is whether you can clarify if you can only use lorazepam with haloperidol.
That's a good question. As opposed, I suppose, to clonazepam. You probably can use clonazepam and haloperidol. You can use diazepam and haloperidol as well. You should be able to use that.
The next question is, can certain medications cause a change in behavior in patients and make them aggressive? And the scenario that the attendee is giving is that they had a teenage patient that was autistic and had a very aggressive behavior and hallucinations after the administration of Dormicum.
Yes, it can happen. There's something, now the word has slipped my mind, but it's the opposite reaction to what you're expecting. And this happens, it's a known phenomenon with benzodiazepines. It frustrates me that I can't find the word now. So you can have the opposite effect. And it's not only, I see that in this situation was somebody on the autism spectrum that had this reaction, but it can happen, unfortunately, and I've seen it myself, that the sedation had exactly the opposite effect, and the person became more agitated and in that situation. So yes, unfortunately, that is the case.
Next question, Prof, is whether etomine is still available to be used.
Yes and yes. It is still available and it is still used quite often, especially if there are stockouts. We use it in our hospital. You do have to be careful with patients with that are neuroleptin naive. You have to be careful with patients with HIV/AIDS because they are more prone to the side effects. Epilepsy, etomine lowers the epileptic threshold. So you need to be very careful with medically ill patients in using etomine, but it is still quite a good drug to use, and yes, we still do use it.
Next question is whether you can elaborate on the link between epilepsy and a suicide risk.
I'm not sure what that's a very good question. I'm not sure what the link is and why the risk is increased. I've actually never specifically read up on this, but we know that certain medical illnesses do predispose to an increased risk of suicide, and even something like long-term worklessness in a patient that previously worked and then stopped working, that was medically boarded and I'm bringing this into the conversation because what is one of my special interests is that they also have an increased risk for suicide, but I actually don't have a good answer for you. The reason I'm going to have to actually read up on that and make a mental note and go and look at what the link is, but I don't have a specific answer for you in terms of what the mechanism is and why that is the case.
The next question, Prof, is in managing a person with addiction and risky behavior regarding self-harm and lack of decision-making capacity. What is the process for involuntary admission?
Okay, so the process for involuntary admission is a family member can apply for admission, and this so this is done on a Mental Health Care Act Form 04. The person who applies for this must have seen the patient in the last 7 days, and it means the person doesn't have to physically be there with the patient at casualties. And then, but the application can also be made by a significant other or even a healthcare provider. And then once that is done, two Forms 05, and I'm not going to go through the whole process, then two mental health care providers who both are psychiatric. One has to be a doctor and the other one has to be somebody with a background in psychiatry. So it can be an occupational therapist, a nurse, a clinical psychologist. They have to separately assess the person and fill out 205s, and that's the first step of admitting a patient under the Mental Health Care Act as an involuntary patient. And the big thing is what you want to know, to put it in very concrete terms, is the person a danger to themselves or to others? And do you think this is an imminent danger? And do they have the capacity to say, I need treatment or not? So depending on whether they say they need treatment, you're going to make them an involuntary patient or an assisted patient, but mostly we use involuntary admission.
The next question, Prof, is in some areas of the country, there's very little available in terms of residential care. Is it possible to have a patient retained in hospital if there is no inpatient care immediately available?
I'm not sure what the person means. But, so coming back to the previous question and connecting that to this question then. So yeah, absolutely. There's very little in terms of residential care available in the area where I live, unfortunately, which makes our lives quite difficult sometimes as psychiatrists, and when we have to discharge patients from our hospital. But in terms of the Mental Health Care Act, so a person is initially admitted to a 72-hour unit, and the idea of the Mental Health Care Act is to exclude any organicity, any physical reasons for the person presenting in this way for the first 72 hours. So the person can be kept there for at least 72 hours, and the Mental Health Review Board here, I think, allows us to keep a person at least for about 10 days there. It kind of differs from area to area, and I can't remember exactly what the Mental Health Care Act says, but you can keep a person and in a we call it a listed facility, a 72-hour unit, for quite an extended period of time, but there is a limit to that time. I can't exactly remember what that limit is offhand now.
Well, I'm going to take two more questions. So the second last one is, there's a participant that's asking that you explain why Clopix or Accuphase won't assist us during an emergency. She's asking if you can elaborate on it.
So it's not acutely sedative. You can actually give it together with your rapid tranquilization. Again, they are similar to etomine. There are certain situations where I would be quite careful with Clopix or Accuphase. Again, in your neuroleptic naive patient, your patient who's never had an antipsychotic, and you're worried about neuroleptic malignant syndrome in a patient like that, or acute dystonia, or acute extrapyramidal side effects, you in your patients with HIV/AIDS, your patients with epilepsy, your medically ill patients. So be careful with clopixyl acufase. But clopixyl acufase is not going to contain the person's aggressive behavior now. In about 8 hours from where you gave the clopixyl acufase, and remember, clopixyl acufase you can only give every 3 days. In about 8 hours, it's going to start kicking in and help calm down the patient. Again, I'm suddenly, after an hour, I start losing my words. It's contained, is the word I'm looking for. Contain the patient. So there's definitely a place for clopixyl acufase. I'm sorry if I confused you in that way. There's a place for a clopixyl acufase, but if you need to sedate the patient now, for example, immediately within half an hour, you want this person contained, then clopixyl acufase on its own is not going to do the job.
Thank you, Prof. The last question that I'm going to take for tonight, unfortunately we've run out of time, is what would be your recommendation to sedate an aggressive pregnant patient?
Excellent question. Promethazine. That would be my go-to first. And then after that, if you don't have promethazine available, it becomes a risk-benefit. It's always, in a pregnant patient, it's a risk-benefit consideration. So what are the risks to this person harming themselves and harming this unborn child? And the risk is not necessarily always self-harm. The risk is if this person picks up a heavy thing, to throw somebody, so many things can go wrong, so many injuries can happen. So then sometimes you have to make a hard decision and you only have a benzodiazepine, and then you will have to do what needs to be done to sedate the patient, and obviously you're going to monitor the baby then to the best of your abilities and make sure that after the patient is sedated, that both your patient as well as the baby is monitored.